Right. So I'm gonna, so this is gonna go rapid at first, and then I think the beauty of this is that understanding that this is just sort of our opening meeting and that we will share emails and conversations in the future. So all these slides that I rush through, we'll be able to revisit in emails and conversations and build really cool stuff. So I'm gonna disclose that. So I have an infectious disease background, and sort of you can see how, time smears from 2003 all the way to 2018, and I started doing outreach. Um, and then I think I'm focused on what's going on right now in 2024 with Mobile Health Initiative, who I joined about a year ago. So I think focusing on the fact that, sorry, um, we, we show up and do this in collaboration, and we don't do this in I mean, this is something that we do together. We have, depending on where we go, we're bringing different supplies. The weather changes, so as you can see in some of these, we're in shorts and t-shirts, and sometimes we're in rain and sleet. Oops. And I think there's a lot of focus on, we have a lot of systems that are, the structure feels impenetrable. It feels that way to our participants and our patients. And we have sort of these innovative, creative groups that are in the community. Some are medical folks, some are non-medical, some are folks with lived experiences. And I think using the resources that we have and then also creating space or using the power and the structure that we have in our systems to have volunteers, have people with lived experiences, but making space or finding opportunities to not just be in brick and mortar, not just be in metro urban areas, utilizing some of these mobile designs, which aren't so familiar, but definitely are the future. In 2018, I think it was we were trying to figure out how to engage with people who were just coming into spaces to get the usual like harm reduction supplies, smoking kits, and those sorts of things. But also realizing that a lot of folks were needing more and not being able to go into like formal medical facilities, not being able to afford to go into Walgreens and pick up. Oh no, what I do here? Sorry. Sorry.
Looks okay on our end. We're looking at some wound kits.
Okay. Yeah. Sorry.
You're good.
There you go. Thank you.
Yeah.
All right. So the wound kits being something that would be more in the community setting would be just sort of the basic, something to clean it, cover it, and secure it. You'll hear that a lot from me. And then also realizing that sometimes the collaborations we have, we can bring more medical folks out with us so that we can do a little bit more. And I think that's what Audrey is going to get into. But it took time and planning and planning with the state so that there could be coverage to support sort of purchasing a lot of these supplies. And then also sort of like creating materials so that there's just sort of a sort of like guide to other ways you can use it. And so developing, this is like version 20 or 50, but having sort of things that sort of, they're not they're not stifling, but they're sort of guides that can be referenced and handed out. And if you want to have a conversation, if the individual wants to have a conversation with the person on outreach, they can, or going back to the kits, they can just sort of grab something that's on the table and maybe you have a conversation 4 or 5 times down the line. But just sort of having a more sort of service and resource forward approach is something that I I like to encourage. Um, this was something that we developed just to have sort of specific talking points. All right, and then I'll wrap this up with other images of second tier items, focusing on what your roles and goals are, so that after conversations happen, you can sort of tailor some of the stuff that folks are getting so that you can, you know, continue to help them and then ultimately link them. Those are lists. This is something that we worked on in Duluth at Harm Reduction Sisters, a space that housed a sort of shelving that let people almost kind of shop for supplies and then have discussions at the level they felt comfortable with. And sticking to an overly simplified, but a clear, clean it, cover it, and secure it so that the items could be sort of like put in easy categories. And then sort of stuff that people already are doing, having a decision tree to just sort of like back that if they're having a conversation with you, or if they're just taking that away, they can follow sort of like a pattern and it sort of endorses what they're already doing. And then these are just different locations and different sort of linkage sheets so that the idea of like connecting, getting people services and supplies, but then also looking for where in their area are they able to go, where they're willing to go, and then just talking that out with them if they're willing to. It can look a few different ways, but sort of having some trusted partners to point out that are close by in the area so that you can almost vet the options for them and then maybe call ahead or call with them. And this is stuff from current work we're doing in Duluth, but this is at different locations, doing foot care, offering different services together. Drug checking is coming out and also being an option that people can know sort of what's in their substances a little better. And then another image of different locations is that South Side harm reduction, just protected spaces so that folks can come in and have a moment to decide what they want to do before they go back into often very complicated and complex situations. And then again, just focusing on services and resources, all that takes time leading toward linkage, but making sure that there's a sort of a welcome back each time, or when can I see you next? And then I think that's this is where I end here, but this is outside of the Duluth Library with another mobile unit. So I'm gonna pause here and hand it over to Audrey.
So my name is Audrey. I am a nurse with Healthcare for the Homeless in Minneapolis. I have been a nurse for just since 2018, 2019, but I've worked with Healthcare for the Homeless since 2019. And I've worked with folks experiencing homeless, like either shelter-based or street homelessness since 2013. And my other focuses at work are Hep C treatment, HIV management, and MOUD connection. So I'm just gonna like dump right into like the nitty gritty here. So the very first thing we need to think about when we see a wound is like determining the etiology. So like, what is the cause of like a wound? In the hospital, you're learning a lot about like pressure injuries and like device associated pressure injuries, and those can still happen like out in the world, out in the wild. And we still need to figure out what is creating an injury for someone, whether it's mechanical, like pressure, friction, or shear, or if it's like a lower extremity wound, trying to classify if it's something related to venous stasis, peripheral arterial disease, or diabetes. And the big things with those three, so for lower extremity wounds, venous ulcers are usually red and wet, super wet. Arterial ulcers are more classically punched out, they're pale, and more on the dry side. And then diabetic foot ulcers or neuropathic ulcers are typically on the foot. You know, the person has diabetes and they have a loss of protective sensation. The added layer for folks who do use drugs, so like many of the people I work with are people who use substances. So like heavy nods from opiate use can like end up with a prolonged period of hypoxia to like a tissue. Like, so I just have someone I saw who has a pressure injury on his elbow because he nodded out super hard, and that's a pretty sizable bony prominence. There's also caustic agents, like things that are cut into the drugs that if someone misses a shot, so if they're trying to inject into a vein, they miss, that can like be destructive to tissue. And then I would bet many people have heard of xylazine. So xylazine is a paralytic that's being cut into the drug supply. It's like ubiquitous across the US. And so people aren't like going out trying to buy xylazine. Like, to be clear, it's incidental consumption of xylazine because it's being cut into fentanyl. It also is cut into meth. So the mechanism behind like why that creates tissue destruction isn't super clear. There's like some hypotheses about how it causes like vasoconstriction in the capillary beds, which like leads to hypoxia, but they typically follow a similar trajectory of starting as almost like a small pimply blister thing, so round, and then they burst open and they will usually get bigger. And you are going to heal these all the same way. All wounds, we are trying to get them into the same like happy category for them to heal, because we are manipulating their conditions by the different kinds of dressings we're using. Okay, so this is the stages of like a wound. So you have like your initial injury, and you have hemostasis needs to happen, and then we go into an inflammation phase where the wound bed needs to be cleaned out. The inflammation phase is often where people get stuck, and where things become very chronic. So the biggest thing I think is important for people to understand about wound healing is like you need to get that wound bed clean and out of the inflammation phase for any kind of healing to happen. After inflammation, right, we've got proliferation. We're having like new blood cells or new blood vessels being built, the angiogenesis, new skin, the collagen's coming in, and then we're making a tissue, like epithelialization. And then we go to tissue remodeling, which is like that scar tissue. Okay. This did not blow up as well as I had liked, but this is just showing different things you might see in a wound bed. So all the way here with like kind of this white yellowy stuff in here, this is slough in a wound bed. The second one here is eschar. The third is an unstable eschar. So the difference is this is kind of like peeling up. So you could technically like kind of take a peek underneath and see what's there. And then all the way on the right is healthy granulation tissue, which is what we want. The way I explain wound care to patients is that it is like Goldilocks. We are trying to get your wound into like the happy middle of like not too wet, not too dry. So many people grew up learning that you should air out your wound and like let it get like all hard and crusty. But like what we know from like medicine and what the science tells us is moist wound healing quickens healing, and it like cosmetically like has a better outcome in terms of scarring. There is also a really great acronym that I like run through in my head called DIWAMOP. And so it's debride non-viable tissue. So when you're looking at like someone's wound, do they have that slough in there, kind of like that white, fibrinous, yellowish stuff, kind of the goo? Do they have eschar, or is there kind of like dead tissue hanging out if it's like a popped blister? So you want to debride their non-viable tissue if it's within your scope of practice. If there's any signs of infection, so redness, pain, malodor, you want to address an infection. We want to wick a moisture away from the wound. So if they have any tunneling or undermining, any kind of like cavities, or if it's kind of a crater, we want to make sure that we have a dressing that's going to allow the exudate to come out of the wound bed and not be trapped in there. We want to have something to absorb all the exudate. So like we're wicking it away and we need something there to hold it when it does make its way out of that dead space. We want to maintain moist wound healing. So that's kind of like just general rule of thumb, creating an environment that maintains most moist wound healing. And we want to assess for open or closed edges. I'll talk about this more, but there's a kind of like a small complication that can happen with wound healing called epiboly, and it's when the wound edges roll over. So you'll see the wound fill all the way up and it looks like it should be healing and it just plateaus. It usually is a result of the wound edges being rolled under and your body already thinks it's healed. So you're not going to get that proliferation of that like final layer of cells of the epithelialization. You want to protect it. So just generally padding it, insulating it from the cold, all that good kind of stuff. Again, just consider etiology. When you're looking at someone's wound for the first time and you're doing an assessment, the first thing you want to do is clean it. You're going to measure it. So you're going to measure length times width times depth. And this is like the nitty gritty, like if you're going to be doing like a DME or something. But like, which I don't expect people to do, but I am just going to give you this info because maybe one day when you're a physician, it will be helpful. So you're going to do a length times width times depth. You're going to describe what the wound bed looks like. Like some of the stuff I see is really like crusty. So I'll be like, this is like, even after kind of trying to clean it up, it's like 100% covered in slough. Or sometimes it actually is pink, healthy, like granulating tissue. So describe what it looks like. You're going to describe the type of exudate. Usually that is kind of like a shared process. Like I'll ask the patient like, hey, how much, is this a super wet wound that you've got right now? Are you having a lot of like exudate from your wound, or is it pretty dry? And you can usually tell from like the dressing you remove, whether it's been like bloody, if it's malodorous, all that kind of stuff. You want to describe the wound around, or the skin around the wound, and kind of assess like, is it still intact and looking healthy? Is it becoming denuded because of like too much moisture, maceration? Is it red? Is it hot? Does it appear infected? One thing that's very helpful if you have capacity for it is after you clean it, after you debride it, is photographing it. So for the team I work on, we have Epic Haiku on our phone. So we're able to photograph wounds in the field and upload them to people's charts. And it's really helpful, like from like nurse to nurse, to kind of see like, oh, that's what that looked like the last time we saw you. Kind of looks the same, or like it looks like we're making progress, or it's really like decompensated and things aren't going well. When they come in contact with the exudate, they start forming a gel. And so you can also get alginates like impregnated with silver. And in that case, they can be left in place for like up to a week, depending on how highly exuding the wound is. Hydrofera Blue is really nice, and I wish I could afford it. It is like a mini wound vacuum. So you like hydrate it and you can apply it to the wound bed. You cut it to size, and it I think it's like -4 like milligrams of mercury, like negative pressure that it applies. So kind of that gentle suction that it does. And like this is how like wound vacs work is they help promote granulation and angiogenesis in wounds. So they're very nice. They're also impregnated with methylene blue, which is a antimicrobial, and someone's calling me at work phone. Oh, antimicrobial, and oh no, it's Dave. Okay, antimicrobial, and it'll change colors when it comes in contact with like high bacterial like bioburden. So it helps indicate when to change it. It can be left in place for 7 days, but if it goes from blue to white, it should be changed sooner. For secondary dressing, so this is what you're going to put on second on top of your primary. ABD pads are cheap. They can absorb a good amount of exudate. This is like mostly what we use at work. You can also use like 4x4 gauze sponges. So just whatever you got, kind of general first aid stuff. You definitely don't want to put gauze ever directly onto a wound bed. It's going to get stuck and you're going to have to soak it off. Hydrocellular foam is really nice. They make it even with an adhesive border, so it kind of turns into like a big Band-Aid. And you can just put that on directly, and it can absorb a lot of exudate. I mentioned zinc oxide as a topical. Bacitracin is one we use often. Vaseline, Aquaphor, or like kind of just petroleum is really helpful for non-infected wounds. You don't need to be using bacitracin, a triple antibiotic, anything like that for something that's not infected. Then some more expensive things. There's medical grade honey, so like Meta honey can be used, and it can be helpful for wounds that are high, like have a lot of slough. Silvasorb, another one's like lends a lot of moisture to the wound bed, so this is more for something that's very dry, like a burn. And then Iodosorb is like very expensive, but it is a controlled release of iodine, so that it is not cytotoxic. So it absorbs exudate and like bioburden, and has a controlled release of iodine to try to bring the bioburden in the wound bed down. These are options for securing. So there's Kerlix or gauze wrap, Coban, and the thing with Coban is you need to make sure you're being you're being gentle, that you're not putting it too tight that you're causing harm to the patient. Ace wrap is another option. The one thing I would warn about that, especially with lower extremities, is for uneven compression, which is why I really like Tuba Grip. It's kind of like a glorified it's like a very weak compression sock, but you just cut it off a roll, and you can slide it up, and it provides even compression on the garment. There's also mesh gauze, like kind of a netting that can be used. And then also you could just use like a big Tegaderm, which is just kind of that sheer plasticky thing you'll see over like IVs and PICC lines, stuff like that. So you could use that if you have it. It can be helpful. Band-Aids are also great. These are my things that I would say be cautious with. So I know sometimes in like volunteer settings, you'll get things just like donated, and it's like, oh, cool, we have this. Like, how can we use it? I see almost exclusively heavily exuding wounds. Xeroform is like a very tricky thing to get right. I think it is really most appropriate for burns and open abdomens, not so much a lot of the wounds that I see, at least. The thing about Xeroform is that it is occlusive, so none of that exudate is going to pass through the dressing like it would with oil emulsion. And so the Xeroform traps all of that moisture on the wound bed, and then it leaks out onto the peri-wound skin, and it macerates it and weakens it with all that moisture, and you can get your wound opening it up even more. Hydrogen peroxide is like an indiscriminate killer of both bad things and good things. So it's kind of setting your wound bed back to zero. So yes, it will kill your bacteria, but it will also kill all your happy cells that are trying to heal your wound. Same with iodine. Uniboots are I don't know if folks have heard about it or are familiar, but they're like a wrap that's impregnated usually like with zinc or with calamine. And they're kind of like old school. I would not recommend them if you get them. They don't provide consistent pressure. Um, and they're rarely like a good option. Then the other thing, just since people are going into medicine here, is my understanding, is just talking a little bit about culturing like a wound bed. So culture should be taken always after you clean a wound. So from clean tissue, not pus. So that is like always such a common mistake, is like we see kind of like this pussy gross thing and we're like, let's culture that. We don't want to culture that because it's going to have everything in it. And what we really want to know is, we don't really need to know what kind of skin flora this person has. We need to know the culprit of that, what's creating like that cellulitis in that wound, around that wound. So there's something called the Levine technique, which is where you take your swab and you're choosing, after you clean, 1 centimeter area of clean tissue in the wound bed, and you're going to rotate the swab to express some tissue fluid in that 1 centimeter area. And like, that's how you should get, because you're going to get like wound exudate on that. And that's going to give you a much clearer picture of what you need to actually be targeting your antibiotics for. Common wound healing complications, infection. So there's critical colonization, which is kind of like you're right at the edge and things are about to pop off into full-blown cellulitis. And that is something where if you can do something to control the bioburden in that wound bed, whether it's through like a silver dressing, sometimes just dumping a bunch of iodine on it, even though it's kind of naughty. But it kind of depends on your access to medical care, like a prescriber, right? Then there's also closed edges, which I talked about. So it's typically a result of not packing a wound and those wound edges curling inward. When someone has this happen, they should see like a wound care nurse or have a consult, because what needs to happen is there has to be a plan to open up those edges. So they need some sort of specialized care, whether it's like silver nitrate application, hydropharablue, or like some sharps debridement. And then there's also hypergranulation, which I have pictures of later, but that is typically due to a prolonged inflammation period. So that second stage of wound healing, so being kind of caught in that inflammatory phase. Here is a cool diagram of a Pibili, so you can kind of see how that wound is curling under the edge. And like the way to kind of correct this is with sharp debridement silver nitrate application, which comes on the swabs, or with hydropharablue, which is that expensive dressing that's like a mini wound vacuum. Hypergranulation. This is typically a byproduct of chronic inflammation. You want to, when you see this kind of happening for someone, you want to assess the wound and assess kind of what dressing selection's been happening, because it can also be an effect or a byproduct of not having the best like environment for healing. So usually too wet of an environment. Ideally, what would happen is like you can correct this with sharp wound debridement, some compression, and also with hydropharablue. Okay. Level of care. If someone has systemic symptoms of infection like fever, body aches, malaise, if you can probe to the bone, so very common with feet, or they have like a wound that's in need of surgical debridement because of like their level of pain, and like potential bone involvement, that's like a good, reasonable hospital referral. There's also a really cool study I just want folks to know about it and telling everyone I meet, called the OVIVA trial from 2019. And so their findings was for osteomyelitis.
I have a question. Thank you for the great presentation. Often I find that people are hesitant, as you said, to be in hospital for a long time or have traumatic experiences in ED. Do you have pearls on how to transition to make it safer for everybody? Like communication wise, warm handoffs, etc.
Yeah. And that was kind of part of a highlight for the other case study. But so what I've had success with, and I would say moderate, it's not like a very exciting success. But if you can go with them, that's great. If you have a connection on the inside of the hospital system at Addiction Med, that's great. I'm assuming so. In my experience, most of the time, people do not want to go because they are going to feel sick. They're not going to have like a line to opiates to like help their brain feel baseline. And then like, of course, right, like on top of that, they're going to be treated poorly. If I can accompany them or if I can send them, we have like some art supplies we give people. We will do that. We will load people up with snacks. Yeah. I will visit people in the hospital if they are admitted, especially early on, to make sure that they understand what's going on. It's been my experience that sometimes our patients, either aren't told or like really just like aren't necessarily like absorbing like kind of what the plan is if they are being told. So I will kind of be like, hey, did you know like this is coming up and do you have questions? Like, do you understand what that's going to mean for like when you get out of here? So I would say try to find someone on the inside.
Sweet. Thank you.
Yeah.
Hi, I have a question.
Yeah.
Regarding this case study and the woman you spoke about, had she had a previous successful experience with you all at Healthcare for the Homeless? So an existing relationship, or is this a new relationship that was formed?
She's an existing relationship. So she comes to us. We also do syringe exchange. So we'd like see her for exchange. And also, I think it was like probably about 2 years ago now, we ran her case for syphilis. So treated her syphilis infection.
I'd also point out that Healthcare for the Homeless is often I speak in my microphone. Healthcare for the Homeless is also strategically at a lot of the events and accessible in like multiple places that folks kind of travel through in their day. Like, so I think all those things sort of add to the trust, and they have multiple locations and folks that do different services. So I feel like you internally refer amongst yourselves, like not only from the SSPs, but you have like folks doing insurance and benefits. And so I think all those things contribute because you're a community in yourself.
And then we even get referrals from Dave too, which is really great. We like overlap in the community and it'll be like, hey, can you hang out for like another hour and see the nurse practitioner and get some antibiotics? So that's been good. The one time I did have to pay someone $40 in gift cards to see us.
As a follow-up question.
What did you use to treat her syphilis with? If she's allergic to penicillin and amoxicillin and all the other cillins?
Yeah, my understanding is she had to be inpatient for that. So I was not part of the team, but like typically, yeah, so she had to be inpatient for that at HCMC for desensitization.
Audrey, can you also talk about, you have med programs where you help deliver folks their medications as they kind of come to events or they cross paths with you all and then they pick up PrEP and other maybe antibiotic?
So wound care is just like kind of this one little like piece, like item on a menu of like services that our team offers. Like, and so clinically, so we have a social service side that can like tie in for benefits, Ryan White funding, housing, just like general systems navigation. And then medically, we do, our team like was born out of a response to the HIV outbreak in our county among people who are unsheltered and use drugs. So we have a team of nurses, nurse practitioners, case managers who work with people who are unsheltered who have HIV. But of course, to be successful in that, we can't let people know that we are there for HIV. So we offer PrEP, We offer hepatitis C treatment, wound care. We do screening, so urine and blood, screening for Hep A, B, C, offering immunization when we have it, Suboxone, all that good stuff. Therapy, diagnostic assessments. And so people will meet us through their family too. So like I get referrals for like, my auntie needs to see you because like she's got a wound on her leg, and like, can you come over to like the projects, like where, yeah.
You talked a bit about what could go wrong, but I was wondering kind of what you see as on a daily basis. Like, what are the most common like struggles you see in relation to successful healing on a daily basis?
The biggest issue, especially, is not having access to a space to do your wound care. So especially if you have kind of like large lower extremity wounds happening that are really like wet and like highly exudative, it's like, and this is like a barrier for me even being able to like provide kind of like good care and like good assessment, is like if I'm just on foot and like I run into someone and we don't have a place to like go and do this, it's like it's a verbal conversation about what's going on, and then I get them stuff from my car. Like I'm not able to do like a proper dressing change because they're not hot to sit on the side of the road and like show the world what's going on with their body. So kind of lack of space.
This actually happened today. I was on rounds. I'm from DC in Union Station, and a woman had a wound on the bottom of her foot. But yeah, that was the biggest thing, was she was like figuring out a place to go. We found a place to go, and then the pants couldn't come off, and the sock couldn't come off. And it's like, okay, now we need to find a better place to go or something else. So yeah, that came up today.
Which is kind of why, so part of like my assessment is often just like, how do you feel like things are going? Are they worse? Because it's like, then I know kind of how much should I push to really be able to get this, like, to lay eyes like on the actual wound. But if they're just like, it's the same, like I just need like Band-Aids, or I just need like gauze, like it's fine. Or like, it's not bothering me, I just need stuff. Then I'm like, okay, cool. Like, you know where to find me. But when people have like a sense of like urgency, that there's been a status change, that's helpful.
One of the medical students wants to ask a question here.
Oh yeah.
Hi. It was really great to hear your presentation today, both you and Dave, who I'm with here today. But I was going to ask a couple questions. One, kind of in reference to your case study, like, when you're encountering people who may not necessarily want to like receive care in like an institution, do you kind of, and this is for Dave as well, do you have like kind of like a flow sheet of like, okay, if you don't want to do this, we can do this. If you don't want to do this, we can do this. Like, you know, the different steps of basically like harm reduction philosophy and like wound care. And then the second question, just so I can get out of the way and sit down and listen to you guys talk, is just kind of like, what are the role that medical students, if any, have played in kind of the work that you're doing? And like, you know, how could you see that playing out if it hasn't happened already? Thank you.
Yeah. I can say, so, how I put it to patients is I'm like, I'm just going to like throw out a bunch of options. And like, so I just want to kind of like think out loud to them and present like 2 or 3, like, we could do this, we could do this, we could do this. And it's like, and I work with a nurse practitioner who is really excellent at this too. And we just saw someone last week who has like has venous insufficiency and like, is having like a pretty mean recurrence of some venous ulcers, on her legs that are infected. She's unsheltered and she needs treatment. We didn't do a culture and I don't remember why, but, she was like, I see that the last time this was cultured, it came back positive for this. So like, I am recommending this antibiotic I can give you today. I could also give you a second antibiotic and take them together and it'll be like, even more broader coverage. And so that patient ended up leaving with like 2 types of antibiotics and started on one with the instruction of like, if things aren't clearing up in 48 hours, like you're not seeing any kind of improvement, start number 2, just to broaden the range of pathogens that it's targeting. So really giving people a lot of options and a lot of autonomy. I really think that our patients like really are in tune with like what's happening in their body and like understanding that like when things are right, or things are going wrong, not necessarily like they can doctor themselves, but like I think that they can really participate in like the decisions about like when to add another agent, or like if things are going okay and like actually like I want to wait like a day or 2 to see if things clear up with my like cellulitis, like with the treatment I'm doing. So I would say offering a lot of options and thinking out loud. I kind of like to think of it as like I have a map and like there's this destination of like you having like a positive outcome, and like there's a lot of different ways to get there. So where do you want to start? Yeah, I can't remember the second half of the question. Oh, medical students, how do they plan? I had a really great referral in the winter for someone with some nasty frostbite from a medical student over at the DSA building. So there was an eviction, and a medical student who I think like was doing, I don't remember, because wasn't he from Duluth, Janie? Did you meet him? Okay. Anyways, he's in the city, and so he called me. So I think it's like a matter of, I think those referrals are awesome because they're able to lay eyes and start giving that information. And also like, depending on where you are in your medical training, right? Like you have like the clinical skills to do a dressing change. So, especially frostbite can take a really long time to do a dressing change because it is so painful that you really want to give the patient, the option to, take breaks. So it was right at the end of the day, and I came and assessed, and I was like, I've got all the stuff. Like, are you able to do this dressing change? Like, I have to go and deliver meds to another person. So, I was able to kind of give like general instruction and supplies, and like connect with the patient and get him a shelter bed for that night so that he like hopefully wouldn't get like thermal re-injury. But yeah, so just making those connections with people who are doing this work, I think is really great as medical students to like be able to have those referrals. And it means a lot to patients to like know that they're going to go see someone who can help them.
I think the only thing that I would add with I think you're absolutely right on with the sort of menu options for what are you thinking? What are the sort of nearby resources that are available? And what have you done in the past that hasn't and has worked? There's also the sort of closing statement of when can I see you again? And kind of with what can I bring with to make you want to see me again? Like if you're bringing harm reduction supplies with or snacks or food, like those things sort of incentivize that sort of like, sure, I'll let you do my wound care and give me some, like some fruit snacks and some like sort of feel good stuff. And I think some of it is that here we have 2 groups of medical students in the Duluth area and then down in the Twin Cities. And I'm hoping that both groups are going to sort of define roles for themselves for subsequent years, because we have this sustainable supply of folks rotating through medical school, and more there's med students volunteering, going out on like weekends with like Southside or different SSPs, and it's showing up and volunteering and then maybe handing out supplies, and then you notice what you notice space for you to do certain things. And some of the stuff with this emerging, so we're doing a lot of rapid testing. There's a lot of time afterward that you could do education, discussion around STIs, being involved in that. So the tester is like rolling people through. I just wonder this sort of like collaboration between like disease investigation workers, the rapid testers, and then the navigation and the education that med students can provide. But I think it's emerging. So I mean, it would be volunteer and then notice what gaps there are, and then see where you fit.
If that's everyone's questions, Thank you again, David and Audrey, for joining us. And yeah, thank you for like sharing your amazing advice with us. And I also know like I was personally interested in wound care, and the basics of that. But yeah, thank you for everyone that also joined today. And yeah.
Thanks for having us. Bye. Good luck.
Thank you.
Yeah.